I really want to thank everybody who is joining us for this webinar with Dr. David Geldmacher. ACA is providing these on a fairly regular basis, and Dr. Geldmacher's presentation will be available on our website. Give us, maybe 36 hours or so to get it posted. But other webinars that we have had this summer are also posted on the website, and there are some really good ones that I think y'all will enjoy. Katie, do you want to say a word about CEUs? Katie Cochran is with us with Home Instead Senior Care, and she provides our CEUs and is just an all-around great friend. Katie, you want to?
Yes. A couple things. If you need a CEU, you have to fill out the survey that is going to come your way at the end of this presentation. You'll get a link to SurveyMonkey. So click on the link, fill out the survey, and in that survey, it asks you for your license numbers. So we will have record. That's the best way for us to get your license number without you all having to email Sherry or Miller to let them know. If you're on here by phone, if we don't see your name, please email Sherry Sparks, and I'm going to type the email address in here in the chat. It's aca2@alzca.org. And you need to fill out the survey by tomorrow. This is only for people who need CEUs. By tomorrow morning at 8, and then we will get your certificate to you. And that's all.
Okay, well, I'd like to introduce Dr. Geldmacher, who probably doesn't need much of an introduction. But as I said, we're just really delighted to have him and provide this research update. There's some things going on that we all need to stay abreast of. Dr. Geldmacher is a professor of neurology and director of the Division of Memory Disorders and Behavioral Neurology at the University of Alabama at Birmingham. He was the first named Warren Family Endowed Chair in Neurology, and he serves as Medical Director for Neurology at UAB. Dr. Geldmacher is the author of A Contemporary Diagnosis and Management of Alzheimer's Dementia, and has published over 100 research articles, chapters, abstracts, and reviews. But those of you who have an opportunity to know him, he is just a warm, caring clinician, and I am very thankful for all he does for Alzheimer's of Central Alabama, and serves on our advisory board and helps keep us abreast of what's going on with research with presentations like this. So Dr. Geldmacher, I don't want to use up any more of your time. Thank you so much for being here today, and we're all looking forward to hearing what you have to say.
Thank you, Miller, and thank you for that very kind introduction. I hope you can all hear me okay. If you're not, make sure your volumes are turned up all the way. My internet has a habit of cutting out right in the middle of these kinds of presentations, so if that happens, I'll try and get back on as soon as possible. Right now, there's no thunderstorms over my house, but that's the other thing that usually happens right in the middle of one of these kinds of talks. So what I'd like to do is to give you a little bit of update on where we're thinking about Alzheimer's disease in 2020. I can tell you it's significantly different than what we thought about in 2010, and that still a lot of textbooks and internet sites are catching up with where we are in the research world today. If you've heard me speak before, then some of this will be information you've heard before. But if this is the first time, you may hear some things a little bit different than what you've seen previously. And of course, that's my goal, to make sure that we're all thinking about Alzheimer's disease in the same way. I think one of the important places to start is exactly how do we use the words? What does Alzheimer's disease mean in the research context that might be different than what you might hear in your doctor's office or in common conversation? And one of the big questions that comes up over and over again is it Alzheimer's disease or is it dementia? And the answer is sometimes it's both. So saying dementia is a lot like saying back pain. It describes the symptoms, and what it really comes to be is then just a description of what the person's experiencing. And just like there are many causes of back pain, like a pinched nerve or arthritis or fractures, there are many causes of dementia. And there are many causes of dementia. Alzheimer's disease is the most common cause of dementia in older people. So dementia means a change in memory and thinking that's severe enough to interfere with everyday life. And Alzheimer's, as I said, can cause this. Strokes can cause dementia, and many other conditions. But Alzheimer's far and away is the most common. There are some terms that we don't use anymore when talking about dementia or Alzheimer's disease. Things like senility and old age and hardening of the arteries. These were used before we had a clear understanding of what was going on in the brain of the person with Alzheimer's disease. And as we've come to understand that Alzheimer's disease and dementia are not a part of healthy aging, that they're not just a consequence of blood vessel disease, but rather a specific illness that has very well understood changes in the brain, we've moved away from these other terms and now want to think about the term dementia and the term Alzheimer's disease. Excuse me. Alzheimer's disease is a public health crisis. Now, we're dealing with a huge public health crisis right now with the COVID-19 issues. Alzheimer's disease has been more of a gradual boil, a gradual increase in the number of cases, but it is at the point of being a major burden to our economy and to our healthcare system. There are almost 6 million people with Alzheimer's disease and dementia in the United States today, with Alzheimer's accounting for about 3/4 of that 6 million. The economic burden to our economy is over $300 billion per year. It's the third most costly illness in the country. And when someone has Alzheimer's disease, it ends up costing almost twice as much to care for the rest of their health care as when compared to people without Alzheimer's. So if we know that a person with heart failure, for instance, would cost a certain amount to their to Medicare and to their health insurance over the course of a year, a person with heart failure and Alzheimer's disease, it will cost twice as much to care for that person. Families also expend significant out-of-pocket expenses in the management of people with Alzheimer's disease. And the average cost to a family is now over $235,000 over the course of the illness. And the number of cases is exploding. So we're expecting another doubling in the number of cases by 2050. And any of you have tried to get an appointment with a specialist for memory disorders, our group in particular, you know that waiting time is already exceptionally long, and it's only going to get worse unless we find out new ways of taking care of people with the illness, add new specialists to the mix, or perhaps if the research continues to be productive, of reducing the number of cases through prevention. So those families that I mentioned that end up spending $235,000 over the course of the illness, there's 17.7 billion hours of informal care being delivered every year. Those of you on the front lines know this, and that the value of that care is also measured in hundreds of billions. In fact, the value of the informal care, if we look at an hourly rate for that family caregiver, is nearly equal to the direct medical and long-term care costs. And how does that caregiving spread out? Well, in a memory clinic sample, we surveyed a number of years ago now on our memory clinic. We asked 81 families, who are caregivers? And the average was that a person with dementia had almost 4 family caregivers, people who would step in from family or family-like roles to provide care, at least from time to time. 81% of them were spouses, and 58% were daughters. And it continues to be the case that women provide the bulk of care for people with dementia in the home environment. So this Alzheimer's disease, when I talk about it, what am I talking about from the biological perspective? Well, back in 1906, 114 years ago, a German neurologist, neuropathologist, Dr. Alois Alzheimer, reported an unusual case of a woman in her 50s who died with what they then called senility, but it was a progressive loss of memory and related functions. And he conducted an autopsy and reported that she had 2 interesting and novel findings for such a young person. He had accumulations of what looked like starch under his microscope at that time. And so he called this amyloid, which means starch-like. We now know that that's an accumulation of a protein, and we now call it the amyloid protein. The other thing he found was these flame-shaped markings inside the microscope slide that he determined were elements that previously had been inside of the brain cells, the neurons. So they're called neurofibrillary tangles. And these two things, amyloid plaques and neurofibrillary tangles, continue to be the hallmarks that we use to diagnose Alzheimer's disease at autopsy. So how do they contribute? What makes Alzheimer's disease happen as a result of these plaques and tangles? Well, let's start with how the brain cells work. So every thought that we have, every sensory experience, everything that we understand in our day-to-day lives comes from electrical signals that travel along a dense network of nerve cells. And they have branches that look a lot like trees. And so this picture here happens to be trees rather than neurons, but the right kind of microscope or the right kind of drawing would be able to show neurons looking very much like this. In Alzheimer's disease, the cells gradually contract in upon themselves, forming that neurofibrillary tangle. The cells lose those connections. So it's like the branches between the trees fall off or get retracted back. And so the cells can't communicate with each other the way they used to. And so this particularly happens at first in the memory systems of the brain. And as a result, we see that people lose those functions related to connections between the brain cells. So how does that turn out to be the symptoms of memory loss and language changes in spatial processing? Well, the brain is organized in such a way that different regions become especially important for different functions. So this is a line drawing representing the left side of the brain, the left hemisphere. And memory functions occur or are focused in the portion of the brain just behind the ear, the temporal lobe, and language functions further up, and spatial processing like navigation further up from that. And what we understand is, as the traditional view of Alzheimer's disease, at least, is as the plaques and tangles spread in the brain, someone moves from healthy aging into mild cognitive impairment, and then through the stages of Alzheimer's disease, mild, moderate, and severe. And by the time someone moves to severe Alzheimer's disease, they have an accumulation of those tangles through broad regions of the brain, and not all of the brain. So the motor regions of the brain and primary sensation like feeling hot and cold, those are preserved. But those thought functions, memory, language, space, vision, and regulation of behavior are where the highest accumulation of those tangles are, and those are the symptoms that predominate in people with Alzheimer's disease. So that, of course, is the sum of a lot of research over a very long time. So if we think about where research in Alzheimer's disease is going on today, there are many, many approaches to understanding it. We look at the causes of the disease. We look at how do physicians and nurse practitioners and others make the diagnosis. We have research on the best treatments, both for relieving symptoms and then hopefully making the illness progress more slowly. And we have research that focuses on care. How do we best take care of people with the illness? What are their needs? And how do we individualize care systems to best meet those needs? So all of those are branches of research. We obviously can't cover all of it today. And to give you a sense of the scope of this, in 2019 alone, there were over 3,800 new English language scientific articles published on Alzheimer's disease. That means for an expert to know all of this, he or she would need to read more than 10 new articles every single day. And that's just not physically possible. So there's no one person that has all of the answers as to what's best in Alzheimer's and what's going on in Alzheimer's disease. So what I'm going to focus on today are some of these, but obviously can't cover all of them. And so what I'd like to focus on today are questions that come up frequently in my care of people with the illness. So what are the genetics, and how do we deal with risk factors? And what actually is happening to make those brain cell connections fail? How do we make the diagnosis in clinical settings? And imaging plays a big role in that. And then what kinds of treatments do we have that might slow the progression of the disease or help people maintain their abilities? So let's focus on genetics first. So I'm often asked in the clinical setting, can I get the gene test? Well, there's a problem with that, and that is that only about 2% of cases have what we call causative genes. And in almost all of those cases, the onset of the illness is before age 50, and half of each generation preceding the individual can be shown to have also early onset Alzheimer's. So there isn't a gene test that's applicable to most people. Those genes that are clearly linked to causing Alzheimer's disease are associated with overproduction of the amyloid protein. And so this old clip from the I Love Lucy show is a good way of illustrating it. So she's working in the chocolate factory, and the conveyor belt's making too many chocolates for her to wrap. And that's what happens with these early onset genes. But for the other 98% of people with Alzheimer's disease, late onset Alzheimer's disease, or better phrase, sporadic Alzheimer's, where not half of each generation is affected very early in life. Those genes don't seem to be associated with amyloid production. They're associated with amyloid removal. So instead of the conveyor belt making too many chocolates for Lucy, it's more like the sink is plugged up and the amyloid accumulates in the brain and eventually overflows to become toxic. Now, how that excess amyloid becomes toxic and triggers brain cell death is still not completely known, but we've made good progress in understanding that. What's important about this is those 30 genes that are affected are not necessarily abnormal. And of course, here's where my computer stops working. We can get it to go. Anyway, there's a lot of variation in genes, healthy genes. There we go. So genes create enzymes. Enzymes cause chemical reactions in the body. So sometimes those chemical reactions are the adding of proteins. That's what makes our hair grow. Sometimes it's breaking down substances, like what goes on in our stomach or in our intestines, where enzymes break down the foods that we eat and turn them into nutrients that we can then rebuild, and it's other enzymes that cause them to build in. And there's a lot of variety in enzymes. Some people have fast-working enzymes and other people have slow-working enzymes. Probably some of you know folks who, for instance, can take a medicine and seems to have no effect whatsoever, and other people are just overwhelmed by side effects by the same dose of the same medicine. That's the effect of fast or slow enzymes. And there's a lot of variety in that. So here's a picture of my family from 10 years ago or so when my son graduated from college at the Naval Academy. And my niece and my wife and my son and my daughter are all there. All of us are different heights, and all of us have normal heights. So differences are not necessarily abnormal. And that's true for the genes that cause Alzheimer's disease, that there are differences within these genes that are normal variations. But if a person accumulates or inherits a number of the, and I'll just use the colloquial term here, the slow genes for metabolizing amyloid, they're more likely to build up that amyloid in their brain. And if people have fast genes in getting rid of the amyloid, they're less likely to build that up. And there are lots of these genes, so there's no two people, or rarely would two people have exactly the same mix of what's working well or what's working more slowly. And so that's why we see so much variation. Alzheimer's disease comes on in people anywhere from their mid-50s through the end of the natural lifespan up through their 90s. And why can you have such a broad difference in the age of onset? Because of these variabilities in the normal healthy genes that we all have. What we do know is that there are some risk factors that can further influence whether Alzheimer's disease comes on. And these risk factors include other illnesses, things like diabetes and high blood pressure, and they include lifestyle factors like physical activity and dietary intake and use of alcohol and things of that sort. Some risk factors make people worse. That's things like the diabetes and the hypertension. And other factors that fall into this risk modification actually are protective, and that's where things like the Mediterranean diet and use of the cholesterol-lowering drugs come in. And so beyond this variability in genes that we have all these variabilities in illnesses and lifestyle. And that explains a lot of the variability in who gets Alzheimer's disease and when they develop those symptoms. So let's go down to the real nitty-gritty. And this is where science has made tremendous progress over the last 20 years or so, moving up now maybe to 25 to 30 years. The heart of the plaque, what Alzheimer himself saw under the microscope in 1906, this amyloid, is produced normally in our bodies. We all make amyloid. And the first step of that is we make a protein on the surface of the brain cell called APP, or amyloid precursor protein. And within that is a section that spans from inside the cell to outside, and that's this colored green in this cartoon. All of us make that precursor protein, and we cut it into bits and pieces. And those bits and pieces act like insulin in the body. They signal from one cell to another. So insulin signals cells to bring in sugar. We don't know exactly what the beta amyloid signal carries. It probably has something to do with maintaining brain cell connections. But that's an area that the research has not yet answered. But beta amyloid and other cuts of that amyloid precursor protein are a normal part of everyday life for all of us. And the traditional view was that amyloid that would be developed normally would accumulate in some people into the plaques, and the plaques would be what was damaging the brain cells. So in this slide down in the lower part, we see healthy cells with those rich branches connecting between each other. And in the cartoon upper panel, we see where the plaque is accumulated next to the brain cell and is interfere physically with the connections. And that's what we were thinking was happening really up through the 2000s. Subsequently, we have learned that that's probably not what's happening, that the plaques are probably the equivalent of a garbage dump. We're taking undesirable things and sequestering them away from where they might do damage, just like we get the garbage out of our house and someone takes it to a dump. What happens in the production of that amyloid is that some of the little amyloid fibers, the ones that are cut out of the long precursor, clump together into triplets, and then triplets of triplets. And these themselves can cause damage in adjacent brain cells. They bind to the surface of the brain cell and trigger a cascade within it, which leads to damage. And so these what we call oligomers, or clumps of the A beta, are a major target for our research in trying to prevent Alzheimer's disease or slow down its progress. Now, one of the things that happens after that oligomer, or those fibers, bind to the receiving brain cell, is it triggers a process where the internal skeleton of the receiving brain cell begins to break down. And that's what the tangle is. The tangle is the collapse of the normal internal skeleton of the brain cell, the microtubule. And when it collapses, it twists together and leads to accumulations of the peptide tau. That tau is what makes up the tangles. And you can imagine, if this is what a healthy brain cell looks like, with lots of branches connecting all of others, as its skeleton collapses in, those connections pull back and the cells can't talk to each other. And that's a neuron, a brain cell that's on its way to dying. So those are what we understand about the genetics and some of the things about risk factors and cellular mechanisms that lead to disconnections. So how do we find those things then in the clinical setting? So you come to see a physician or a nurse practitioner about what's going on with someone's memory, and we will test the memory. We'll ask questions to see what kinds of memories are preserved or what ones are more of a struggle. But most of us who practice in the world of neurology, at least, will get some pictures of the brain, some imaging. Now, there are ways of getting images of the amyloid. Right now, most insurers do not pay for this kind of testing. It's a research tool. And you can see some of the reasons for confusion here. These on the left-hand side of the screen are the brains of people with clinical diagnosis of Alzheimer's disease. And they've undergone a special kind of PET scan that detects amyloid. One of them is called the PIB scan. And some people with Alzheimer's diagnosis have lots and lots and lots of amyloid throughout the brain. These bright yellow signals indicate that. But others with an Alzheimer's diagnosis do not have as much. There are people whose memories are still functioning normally, who would not have a diagnosis of Alzheimer's disease, who are accumulating amyloid. What this tells us is the process of those plaques building up in the brain begins before we have detectable memory loss. And that's been one of the major research breakthroughs in the last 10 or 15 years, is this understanding the disease process is already going on by the time symptoms emerge. So although this is a great research tool and we use it in our own research programs at UAB, it's not something that's out there for general clinical use yet, and we really don't know how to apply it in general clinical use. That's one of the reasons it's being studied in research, is what is the applicability to the person who comes in with memory complaints. Another way of assessing whether Alzheimer's disease is present in the brain is with a PET scan that looks at sugar metabolism, or what we call FDG PET. And in a healthy brain, there is good metabolism of sugar, high energy consumption throughout the gray matter of the brain, all the way around the rim of the brain. People with Alzheimer's disease, where those tangles have interfered with the brain function, brain cells are dying in the memory and the language and the spatial processing areas, those areas burn less sugar because there are fewer cells there. And so instead of seeing that bright rim of high sugar consumption, we see cold spots where the tangles are accumulating in the brain. And we sometimes can use this kind of scan in the clinical setting to distinguish the cause of memory loss. Medicare has some very restrictive rules about in whom we can get these kinds of scans, but we're having better luck with getting these kinds of scans in the right kind of people these days. But that tells us at least where the brain is active and where it's less active, and that can match up with what we see in the person. The newest type of imaging that is being studied in research is looking for the tangles. That's I mentioned previously, looking at a protein called tau. This particular chemical agent that's used in the PET scans is called fluorotaucipir. And in the PET scans here, where the tau is located in the brain, where the tangles are located in the brain, is where the red is. That's the highest signal of tau. It matches pretty closely with what I showed in the lateral view of the brain, the posterior or more rearward regions of the brain showing more tau. And over the course of time, that spreads, and we now think that the tangles actually spread from one brain cell to the next, almost like an infection spreading from one brain cell to the next, but it's not a bacteria or a virus, it's a protein that's spreading. So these are important research tools for understanding the mechanisms of Alzheimer's disease and how we can confirm diagnosis in people with the illness. I do anticipate over the course of the next 5 to 10 years that PET scans like this are likely to become a much bigger part of our routine clinical practice. But right now, they're primarily research tools. The type of scan that we can use routinely in clinical practice is an MRI scan, and sometimes PET scans for people who can't tolerate MRI. What I'm showing here is an MRI of the brain, and it's in this vertical plane, cutting the brain sort of front versus back, that allows us to look straight into the middle of the brain, basically. In Alzheimer's disease, one of those areas that builds up the most tau and where there's the most brain cell loss is in the portion of the brain that helps us make new memories. So people with shrinkage in this area have a hard time learning new information. They may not be able to keep track of the day or the date, but old information, where they went to college, what's the names of their sisters and brothers, that's retained. As Alzheimer's disease progresses, we see more and more shrinkage in the hippocampus, this memory forming area. And we now have scoring scales that we can use to help understand how much damage there is. So in a healthy person in their 60s or 70s, we look at these regions of the brain that are outlined in purple and green and blue, the memory forming regions of the brain. And then we understand that in Alzheimer's disease, and this is a person with advanced Alzheimer's disease, there's shrinkage in particular patterns in those areas. And those patterns tell us that it's likely to be Alzheimer's disease as the cause of the memory loss, as opposed to some other condition. And so we can't see the plaques or tangles themselves, but we can see the effects they have in causing brain shrinkage. And that's what we look at with the MRI scans. And in the clinical setting, this is our current best tool for anatomical diagnosis. So we have our clinical patterns of what kinds of cognitive tasks or memory and thinking tasks does the person do well. And then we have our imaging to support which parts of the brain might be damaged or showing signs of shrinkage that could cause those symptoms. So overall, if we take this accumulation of knowledge about the amyloid, plaque not being the problem, but the fibers of amyloid attacking the brain cells, leading to tangles, looking at the imaging of where the amyloid is in the brain, and where the tau is, and where the shrinkage is, we come to this set of curves, and this was a hypothesis now back in 2011 that really turned the world of Alzheimer's research on its ear. What it summarized, this is a model more than it is actual research data, although in the last 10 years there's been plenty of data to support this, is the first thing that happens in the brain is the amyloid starts to accumulate, and that can be measured by the PET scans. There are also ways of looking at it in the spinal fluid with lumbar puncture. So in our research processes today, PET scans and spinal taps are our earliest way of detecting changes of Alzheimer's disease. The next thing that happens after the amyloid begins to increase is we begin to see losses in the synapse, or the function of connections between the brain cells, less energy consumption. That's what the FDG PET shows. Then we see tangles begin to accumulate. All of this is occurring before there is any sign of shrinkage and any kind of memory loss. Memory loss just begins and is very mild at first, mild cognitive impairment. The challenge for us in clinical settings is that all of us have some changes in memory as we grow older, and the earliest changes in memory associated with Alzheimer's disease look an awful lot like the earliest changes of memory that go on with the aging process. Our challenge is that by the time those memory difficulties show up, that the person's amyloid and their brain cell loss and their accumulation of tau has already reached very high levels. And so we may not be able to reverse that memory loss because the damage that's causing them has already reached maximum in the brain. So this is a big challenge for us. And it means that a lot of our treatment research is now moving back to where these abnormalities are detectable in the images, even though the person may not be showing any physical signs or memory signs at that point. Okay, so obviously then we want to figure out ways of reducing the progression of the disease. I'm going to talk about treatment research now. I'm not going to talk about our existing drugs. They've been around now for 20 years or so, and they're pretty well understood. And in the time we have available, I thought it was important to think about how do we reduce progression and how perhaps can we prevent the disease. So I want to take a theoretical approach first. So we now know that the changes in the brain are occurring before any symptoms become evident. So we have people who are asymptomatic and people who have symptoms like memory loss. But the loss of function occurs over time. Obviously, what we all want is a cure. We want to be able to begin a therapy and restore a person back to health, just like we do with antibiotics for pneumonia. So far, that's been elusive throughout all of neuroscience, whether it's dealing with stroke or brain injury or brain cancer or Alzheimer's disease. Having brain cells go back to normal function after they've lost the function is an extreme challenge, and we have not been successful in That's one of the holy grails in all of neuroscience research. So the next best thing we might be able to do is to stop the disease process, to stop the loss of function, and prevent it from getting any worse. And this is why early diagnosis becomes important, because this is a much more realistic goal with our current knowledge and what we're learning about brain cell loss. If we can't get something as complete as stopping the disease, maybe we want to slow it down. And we now know in other neurologic diseases, multiple sclerosis specifically, that we are able to administer treatments that will slow down the progression and allow people to maintain higher qualities of life and higher levels of function for longer periods of time. They still have the disease, it's still getting worse, but we've stabilized it. In Alzheimer's disease today, we have drugs that provide symptom benefit. That is, they might improve memory for a brief period of time. In general, people on the medicines do better than they would if they were not on the medicines. But the overall rate of progression, the rate the disease is getting worse in the brain, is not affected by these medicines. And of course, it is possible to combine some of these treatment effects. So we might be able to slow down disease progression and treat the symptoms that are there. I mean, that's something that's realistic for the foreseeable future, that we might be able to do those things. In the long term, what we'd like to do is to move the threshold for diagnosis all the way back before there are any symptoms. And then drugs that do the exact same thing would prevent Alzheimer's disease, or they would protect the brain and delay the onset. And this is what we've done with heart disease. So back in the 1960s, we understood someone had heart disease when they had a heart attack. And they would go in the hospital for 3 weeks and they'd rest and recover. But there was no way of identifying things before the disease process started. Then in the 70s, we began to recognize that high cholesterol levels were associated with an increased risk for heart attack. And by the 80s, we were able to start to lower cholesterol levels. And then by the 90s, it was very clear that the rates of heart attack and stroke were dropping because of this recognition that we could treat the disease process based on a biomarker, based on that high cholesterol. And that's what we hope to be able to do with Alzheimer's disease. One of the other very promising areas for this early detection is, for the first time in this last couple of years, there has been progress toward blood tests that would be able to identify the amyloid protein and the changes in the amyloid protein very early on in the course of the illness and give us an opportunity for intervention. Just to give you an idea how complicated this is, a drug development that is taking someone with a brilliant idea about what might work in Alzheimer's disease, actually getting a drug into the marketplace, is a long, difficult, and slow process. It takes about 10 or 15 years on average for a new medicine to reach market. And this is regardless of which disease state we're talking about, whether it's something like heart disease or cancer, or whether it's something like Alzheimer's disease. And these are the scientific and pharmacologic steps that are necessary to get there. And each of the yellow arrows is an opportunity for where you have to go back to if you get a failure. And so if we look at this overall, again, this is not specific to Alzheimer's drugs, but rather drugs in general, that we now use computer models to screen thousands of potential molecules for a specific target. Maybe 250 of those will reach testing in animals to see if they actually do in the living organism what the computer model says they might do. Maybe about 5 of those will make it into early human testing to get one drug out into the marketplace. And so this is something that we're trying to do at UAB, is to compress this time course. So we work very closely with Southern Research Institute that has the computer models for new molecules. We have scientists throughout the institution and actually throughout the state of Alabama at places like Auburn and Tuscaloosa, coming up with ideas about what a target might be for a drug to work on, and then collaborating through Southern Research and the Alzheimer's Drug Development Foundation to come up with these models and test new molecules. By the time I get involved as a clinical neurologist who tests new medicines, we're here at this phase 2 and phase 3. So I'm at the narrow end of the funnel, but my colleagues who work in the laboratory are back at this broad end of the funnel. So you might think that stopping amyloid production would be a good idea, and it turns out it's not. So what we've learned is, and I go all the way back to early in the talk, is that it's not amyloid overproduction that seems to be the problem in the vast majority of people. It seems to be that people don't, the body isn't getting rid of the amyloid the way it should be. So a couple of years back now, or about a year ago, they reported the outcomes of several medicines that were designed to completely block the production of amyloid. That is, we're not going to make any more amyloid in these brains. And they made it through the animals, and they made it through the safety testing. They made it to humans. They were tested in 1,200 humans. A lot of people. These are people with Alzheimer's disease. And those who were on the drug did worse than those who were on the placebo. So stopping the production of amyloid was bad for people, made their cognition worse. And this is because, in all likelihood, some amyloid is necessary. Just like our body can't live without any cholesterol, we need some fat, we need some cholesterol. We can't get by with no amyloid. So some folks are trying to find medicines or doses of these medicines that might reduce the production without stopping the production. But this is a real problem area. So the other thing that's been looked at is getting rid of the amyloid, helping to remove it from the brain. And we've had trials going on with this going back all the way to 2005 and 2006 with vaccines against the amyloid protein. And we found over the course of this last 10 or 15 years, and I've been involved in many of these studies personally, that we are very good at removing amyloid from the brain. But that does not translate to improving memory or daily function in those people. So we've had to move the treatments earlier and earlier to people with less and less impairment. And we started to get some tantalizing hints of success. This was published back in 2016 now, I think. Yes, September 2016, where over the course of a year, people received a treatment, this drug called aducanumab, that removes amyloid from the brain. And these PET scans are illustrations of how the red amyloid signal at the beginning of the study was reduced in people who took the active form of the medicines and increased in people who took placebo. They looked at how effective this might be in slowing progression at 6 months and found no real benefit. Everyone was about the same 6 months into treatment as they had been when they started. But they planned for the study to go out actually beyond a year. So at the 1 year point, they found that people who were getting the highest dose of the medicine actually had less progression. They were more stable. And people who were getting the placebo had more progression in their overall severity of dementia. And the other thing that's always encouraging to us in the world of treatment trials is the dose response curve. So the higher the dose, the more effect we saw. So we learned two things from this. You need high doses of the medicine, and you need to be administering it for a long period of time. Basically, you need to be patient. Let's put the patients into perspective this way as well, that people who take a statin drug, a cholesterol-lowering drug, don't start to see the risk for heart attack begin to drop probably for 2 to 3 years after starting the medicine. It takes that long for that cumulative effect to kick in. And so we're seeing a somewhat shorter time course with these medicines in Alzheimer's disease, but it still takes time to show up. So this medicine, aducanumab, made it to the next type of testing, large scale. So now we have it in over 1,600 people. It was tested over the course of a year and a half. And over that year and a half, people who receiving the high dose of the aducanumab showed somewhat less worsening in their memory. Now, the effect was not a big effect. This is a test that many of you may have administered or had experience with getting tested on, called the mini mental state. It's a 30-point test of memory and concentration, and remember these 3 words and draw this picture and those sorts of things. And over the course of 6 months, there was no difference by treatment group, just like in the earlier study. And at the end of a year, the treated group, especially the high dose treatment group, was starting to separate from the untreated group and the low dose group. And then out of a year and a half, we start to see a notable difference. So the assumption is the longer you're on this medicine, the bigger the effect will become. But this is a year and a half. That's a substantial period of treatment. And one of the big questions is going to be, is this enough to justify the cost of the medicine, the risks of infusing a drug every month? It's an IV infusion. And the medicine probably will, in terms of raw costs, be measured in the tens of thousands of dollars per year. However, the company, Biogen, that makes this medication, is confident enough in the results that just last month, just in June of 2020, they applied to the FDA for approval for this medicine to be used in routine clinical care. The FDA has not responded yet as to whether they've accepted that application. That's the first step. And then the second step is then they will review the statistics. And the scientific community has got a lot of concerns about the validity of these numbers and whether this accurately represents the medication's effectiveness or not. But for the first time in a long time, it looks, or a company has submitted an application to the FDA for a new medicine to slow the progression of Alzheimer's. Another question I get very frequently is, what about stem cells? Why aren't we doing stem cells in Alzheimer's? Well, one reason is one of those early slides I showed, where it showed the tangles through broad areas of the brain. There are literally millions of brain cells that are lost in the process of developing symptoms of Alzheimer's disease. And when we instill stem cells, we are instilling dozens. So it's the order of magnitude, several orders of magnitude. We can't put enough new cells into the brain. That's one problem. The next problem is the environment. So our brain develops over the course of the 9 months we spend in the womb, and we are born basically with all of the brain cells we will ever have throughout our life. There's less than 1% new brain cells grown over the course of a human lifespan. And they all grow up together. And so by the time we get to be 55 or 75 years old, our brain cells have developed this rich interlocking network, a lot like the trees in a forest. And if we plant a new one in that forest, the environment around it is very, very different than when they all grew up together. And so it would be a lot like taking a pine cone from one of these big adult pine trees, maybe a pine cone from this one that died recently and fell over, planting it in the ground underneath all the ferns and all the tall pines, and then saying, okay, go do what your father did. It took 70 years for this tree to get to be that big. It took 70 years growing up in a neighborhood with other trees. And so that's our big problem with stem cells, is the time course and the number. We can't put enough of them in, and we're putting them in way too far behind in the timing of when the other brain cells around them grew together. We have much more promise for stem cells in illnesses like Parkinson's, where there are many, where the amount of brain cell loss is much, much less, and it's in a much tighter geographic area. So let me summarize. We have made great progress in knowing what Alzheimer's disease is and how to diagnose it. When I gave my research update talk in 2020, it was a lot different. In 2000, it was a lot different than the one I give in 2020. There's been tremendous development. And remember, over that time, 20 years of publications at a couple thousand or more per year, there's literally been tens of thousands of research articles and ways that we've expanded our knowledge. Developing treatments is a slow process. We have to understand the targets, and that's really the hardest part. And then we have to balance safety and effectiveness and cost. It's a technically challenging process, and it has a lot of pitfalls, and that's one of the reasons we haven't been able to come up with new treatments or new medications over these last 15 years. Our future treatments will likely be very different than what we anticipate today in Alzheimer's disease. They will be more like what we do for heart disease. And sure, for heart disease, we do things like valve replacements and bypass surgeries and heart transplants, but that's our last ditch, our last step. The way we treat heart disease today is we lower the cholesterol and we get the blood sugar under better control, and we keep the blood pressure in healthy ranges. And I think that's what we're going to see in the long term, that will reduce the number of cases of Alzheimer's disease and the burden that it places on our society. Already, in some studies, the same kinds of studies that showed us that cholesterol was an issue in heart disease, we're beginning to see that lifestyle approaches, healthy approaches to brain, or good approaches to brain health, are reducing the number of cases of Alzheimer's disease at any given age. So that if 20 years ago, 25 people out of every 100 in their 80s would develop Alzheimer's disease, maybe now that's 23. So we're seeing improvement in the number of cases per age. Unfortunately, or fortunately, depending how you cut the cake, more and more people are living to the ages of risk. So what I'm going to do is stop the formal part of the presentation, but I do want to let people know that if they're interested in being a part of the research and helping us in answering these very challenging questions, that we have clinical research programs that go on at the UAB Alzheimer's Disease Center and in the Division of Memory Disorders. And our overall intake number there is 996-3679. And for those of you who are interested in the prevention side, there is a national web-based study called the APT, Alzheimer Prevention Trials Web Study, where you can go to this website and register and provide some information. And some people are actually then invited in for in-person evaluations to see if they qualify for treatment trials for prevention. Good places to get information about Alzheimer's disease and what at least I consider to be reliable information are through our Facebook pages at Memory Disorders and through the ADC, the Alzheimer's Disease Center. And then our Alzheimer's Center also has a Twitter account. When breaking news comes out, we will often use that to communicate out to folks. So those are good places to learn about and continue to stay current with what's going on in the world of Alzheimer's research. So I will stop with that. And if questions have come in, I'm happy to try to answer some of
them. Katie, are you going to look at the chat questions? While she's doing that, Dr. Geldmacher, can you tell us what you think about brain supplements, Prevagen?
Sure. So there's a huge market, a completely unregulated market for those kinds of supplements. They work, most of them work on the assumption that somehow Alzheimer's disease is related to a deficiency, a nutritional deficiency, that by taking a vitamin or taking some plant-based product that you will restore something that's missing. And that's not what we understand about Alzheimer's disease. It's not known to be due to any particular or even any pattern of nutritional deficiencies. We know that healthy diets are good for the brain, that antioxidants are good for the brain. But once a person has symptoms of memory loss, there's been no study that's shown that taking a vitamin or a supplement or a proprietary product will improve the results. In the case of Prevagen in particular, and I see the commercials on TV when I'm watching, one of their claims is that if you swallow, basically eat, this jellyfish protein, that it will somehow get into your brain and sharpen your brain's performance. Well, if that were the case, given all the hamburgers I've eaten over my life, I probably look like a McDonald's or a cow, based on if what I ate got into my body whole like that. But instead, what our body does is it uses those enzymes to break down nutrients, proteins in particular, down into their building blocks, and our body makes new things from that. So in general, if there's something that you want to take, they're going to be safe, they're not going to be harmful, but I also don't anticipate seeing big results from them. And that goes back to things like coconut oil, Prevagen, and all sorts of the things that we've seen advertised on TV over time.
Dr. Geldmacher, there are a couple of questions. One is, please say more about other treatments, and then estrogen, question mark. Okay,
so other treatments. Our existing treatments, a class we call the cholinesterase inhibitors, is been around since 1993, actually. What we know about them is that they stabilize symptoms. They will delay progression. So people who take the medicines have less decline in their memory scores for about a year or so. And that over the longer run, people who take those medicines will do better on medicine than they would without, even though they might be worse than where they started. We often will supplement those with the medicine called Namenda or memantine. And that has been shown to help boost the effectiveness of the cholinesterase inhibitors, but for a relatively short time, 6 to 12 months. And that's what's available to us right now. There are no other prescriptive therapies. When it comes to estrogen, it's a mixed boat. If we look at postmenopausal women who do not have any of the menopausal symptoms, like hot flashes and night sweats and things like that, estrogen probably increases the risk for dementia. And that's from a study called the Women's Health Initiative, published back in 2004. For women who do have hot flashes, night sweats, and the like in the perimenopausal years, estrogen therapy can help relieve those and actually can help sustain memory. But for those who don't have menopausal symptoms, we recommend against estrogen therapies. The second question that I can read here is, does aducanumab have any potential in helping someone with tau issues? So if tau is the primary issue, like what we might see in the illness called frontotemporal dementia or progressive supranuclear palsy, aducanumab is targeting the amyloid, and amyloid is not a problem in those diseases and therefore would not be helpful. We actually are testing some anti-tau treatments right now as well, but those are not as far along in the testing process, and we don't have any clinical results at this point that are out there to share. We know that biologically, that those treatments, the anti-tau treatments, are very good at lowering tau levels in the brain, but we also know that the anti-amyloid medicines were very good at lowering amyloid, but did not improve clinical symptoms. So we're still studying the anti-tau drugs for their ability to influence progression. All right. Any other questions that I can address today?
I've got one for you. There was a national Alzheimer's plan to find a treatment for Alzheimer's by 2025. And a lot of the advocacy groups have endorsed that. Do you think that that's realistic? And if not, what do you think is a more realistic goal?
So I think it is realistic that we may have better treatments for Alzheimer's disease by 2025. The federal investment in Alzheimer's disease has doubled several times since the National Alzheimer's Plan went into place, and has been a great resource to us in the care of people with Alzheimer's disease and research into better methods. So I do think that a medicine like aducanumab or something like that is likely to be out there, but it's always a gamble. That's why we do the tests. And so we're testing more medicines and testing more diagnostic processes and moving the diagnostic line earlier in the course of the illness. But I don't know whether we'll have a prescription drug that will have wide uptake and easy use by 2025 or not. But certainly the National Alzheimer's Plan has facilitated much more development of drugs and drug testing than we were able to do before that plan went in place. So on the whole, I think it's been a success. I see a question came in the chat box. 6 to 12 months is the optimal amount of time for Namenda, not much effect after that. That's what the research studies show us, that in people who took the medicine for a year versus people who took it for 6 months, and this is for people with moderate to severe Alzheimer's disease, at the end of that 6 to 12 months, there was no difference. So it didn't matter whether you started early or started late. On the other hand, this is a very individual thing, and there are likely to be some people who do get some effect from the Namenda that goes beyond 6 to 12 months. So often we'll try to do is to reduce the dose or stop it, and then if the person gets worse upon treatment discontinuation, then we know, oh, that medicine was helping them at that time, and we'll put them All right. I see a question has come in about participation in UAB research and the next opportunity for tau scan research. We have some limited studies that are available, and we are launching our Alzheimer's Disease Research Center initiative, which will include some tau scanning. So my recommendation is, if she's been, your wife has participated in research before, contacting the research program and letting us know, letting our coordinators know that you're interested in coming back in, and we can let you know about scheduling specifically. And that's at that, if you worked with a coordinator before, calling the person you worked with before, or otherwise the 996-3679 number is the best one. Okay, that's 3 o'clock for me. So I hope everyone found this useful, and if you have feedback for Miller and ACA that might make a better presentation for me in the future, please let us know. I'm always happy to adapt to the needs of our audience. Thanks for inviting me to be a part of this today. And I'm going to sign off.
Thank you.
All right, you're so welcome, Dr. Geldmacher. We appreciate having you as a part of this. I just want to remind everybody that if you've got family members or friends that you think would enjoy watching this webinar at a later date, that it will be available on ACA's website. That's alzca.org. Katie, do you want to say something about CEUs one more time?
I think we only have one person on here by phone, and hopefully they have emailed Sherry, or they can put in the chat box who you are. But I've put the survey link for those of you who do need CEUs in the chat, and you'll also get the link once this is finished, once we end the meeting. And I think that is about it, Miller.
All right, well, thank you so much, and thank you, Katie and Home Instead, for helping with the continuing education credits. We appreciate that very much. And again, thank you to Dr. Geldmacher for his informative presentation.
Yes.
I'll take care. And everybody wear your mask and stay well.
Yeah.
Bye.
Bye.